A quick word from our sponsor, Oakstone CME, the exclusive provider of ACP Mixap Audio Companion. Okay, what if I told you that 11 minutes of your walk to work could help you prep for boards? Okay, the Mixap ACP Audio Companion breaks down topics into short, focused episodes, usually around 10 to 20 minutes. So instead of needing a full study session, you can actually learn in the margins of your day. And here's a clip.
If there's no obvious cause for the hematuria, then the patient should undergo renal function testing, cystoscopy, and imaging, and then nephrologic evaluation if there's proteinuria, erythrocyte morphology abnormalities, or other signs of nephrologic disease.
It's expert-led, high-yield, built for real-life learning, plus you're earning CME while you do it. For me, it's less about finding time to study and more about finally using the time I already have. Use the code CORE25 for 25% off at the checkout. Visit oakstone.com/mixap and use the code CORE25. Here at CoreIM, we're talking about the real things that can help anyone who works in healthcare. And today we're talking about how the scrubs you wear, they can make a difference. I remember the first time I saw one of my colleagues walking into a sign-out room looking way more put together after a night shift, and I knew right then and there they were wearing FIGS. FIGS Scrubs is made specifically for us doctors, residents, students, healthcare professionals who are putting in long hours and really need gear that can keep up and perform on our level. We have so much going on in any shift, right? Scrubs are the last thing we want to be thinking about. And that's why FIGS is great in that they're lightweight, stretchy, breathable. They have all the small touches that have made me a true convert. They're clean, they're modern, super functional, tons of pockets that I love for all the snacks, zippers that don't snag, and antimicrobial fabric to stay healthy while working. You deserve better scrubs. You deserve FIGS. So head over to figs.com and enter FIGSRX at the checkout for 15% off your first purchase. That's figs.com, promo code FIGSRX for 15% off your first purchase. And with that, let's head back to the episode.
My recommendation is the following 2 words: go in. Like, I see everyone stop at the dialysis unit at the door and they turn around, they do their rounds and they say, oh, we'll come back. And they don't ever go into the dialysis unit. So just go inside. And I think that really the cool thing about dialysis is it's really not complicated, but it's pretty darn life-saving.
That's Dr. John Danziger, a nephrologist at Beth Israel Deaconess Medical Center. Welcome to the CoreIM 5 Pearls podcast, bringing you high-yield, evidence-based pearls. I'm Dr. Shreya Trivedi, and I'm joined by...
Hi, I'm Dr. Nathan Kulapur, an internal medicine resident at Beth Israel Deaconess Medical Center. Today, we're talking about fluid management in end-stage kidney disease patients on hemodialysis. And we'll be using the nomenclature of ESKD instead of ESRD.
I did not know that. And Nathan, why did you say end-stage kidney disease and not end-stage renal disease? Why are we saying ESKD now, not ESRD?
Yes, so there's actually this movement in the nephrology community to use nomenclature of ESKD over ESRD because most people outside of medicine don't know what the term renal means.
Yeah, I definitely didn't know that, but let's get into it. I am so excited for this episode. There's so much good teaching here and so many things I wish I'd known earlier on.
Exactly. So let's get into it and run through the 5 pearls for today's episode.
Yes, and remember, the more you test yourself, the deeper your learning gains.
Pearl 1, Foundations of Dialysis.
What does dialysis do compared to a normal kidney? And how does that explain why your patient's creatinine is sitting at 7?
Pearl 2, Distinct Physiology.
What can autopsies of patients who have end-stage kidney disease tell us and teach us about what physiology differences there are?
Pearl 3, The Importance of Fluid Management.
Why is fluid management the number one priority in end-stage kidney disease patients?
Pearl 4, Fluid Management Pro Tips.
How should we counsel our patients in terms of helping them manage their volume status?
Pearl 5, Residual Kidney Function.
All right, what can patients who still make urine do on non-dialysis days to optimize fluid? So let's start simple. What is dialysis actually trying to do?
At its core, dialysis does two things. One, clearance, which is removing toxic particles like urea. And two, ultrafiltration, removing excess salt and water. I love Dr. Danziger's analogy of a fish tank.
I like to think about it of us just as like a large tank, almost like a fish tank. And inside that tank of fluid, there are cells, and the cells are constantly making byproducts which have toxic potential, right? But if you talk about your tank and you talk about the liters that are cleared completely of the particles inside, so now you have that same amount of fluid, but there's no particles, that's clearance. And so clearance is the concept of particle removal. And then the other one is actually just fluid removal. Like, how do we get rid of the salt and water in the tank? It's really these two concepts that are so fundamental. How do we talk about clearance, which is a mirror image of removing toxins? The liters clear particles, but clearance refers to particle removal. And then the other concept is this idea of ultrafiltration, which is the removal of fluid, which is essentially salt and water. And so dialysis has to really achieve both of those.
Now, with that, how does a dialysis machine actually do its two jobs?
So we're talking about hemodialysis, not peritoneal. And in this case, the machine is taking the blood from your body, running it into the machine one way, and then you have a separate fluid called the dialysate that runs in the opposite direction. And these two fluids are separated by a dialysis membrane. And the concentration gradient between these is what helps with clearance.
Great. And then the fluid removal is a bit simpler.
So fluid removal is very easy. Essentially, these filters, the nurses can basically change the pressure across the blood supply. And by increasing the pressure across the blood supply as it's in this dialysis filter, they can squeeze out protein and cell free fluid. And essentially, what they're squeezing out is basically serum. So you'll get, everything that's in your blood, your sodium, your urea, your potassium, etc., will come out with the water. So they're putting pressure, there's ultrafiltration, and they can move salt water and everything else out into the dialysate. And that's essentially how they affect fluid removal.
Okay, so it's hydrostatic pressure that pushes protein free fluid, so plasma water and dissolved solutes, across the dialysis membrane.
And so the prescribing nephrologist really has two things as well: how much clearance I'm going to give them and how much fluid I'm going to take off. And those are two components of a prescription. So most patients, depending on their body size, need 3.5 to 4 hours to reach the clearance that we set as our goal, which is cleaning the total body water 4 times per week.
Now, let's get into some math. And I have to say, once I understood the math a bit, it really clicked for me why our patients' labs look so different.
We'll detail the full calculations in the show notes. Prepare to be mind blown.
It really is.
Yes, so based on a normal GFR of 120 milliliters per minute, an average weight of 60 kilograms, which equates to 40 to 50 liters of water, the frequency this total body water ends up being filtered is 30 times per week. But a standard dialysis session, that equates to the total body water being cleared around 4 times per week.
Yeah. And so, just to say it again, if we compare a patient who's on dialysis, they get their total body water cleared 4 times a week. But someone with normal kidneys will get their total body water cleared of toxins, urea, creatinine 30 times a week. So 4 versus 30. That ratio is about 1/7. And that's exactly why patients' labs look the way they do.
So a well dialyzed person gets about 1/7 the clearance of breakdown products as a normal individual. So what's a typical creatinine in dialysis? Around 7. Right? A normal creatinine for most of us is around 1. If we're getting 1/7 the clearance, the typical creatinine on dialysis is around 7. Now, of course, if you're a tiny woman and you have a small body mass, you will have 1/7 of your normal weight. And so there's a variability in this, but I think it does at least give some idea as to what a typical electrolyte panel looks like in hemodialysis.
All right, so that's a bit of a mind shift here, right? Like when we see that creatinine of 7 on a BMP, that's actually a well dialyzed patient. And then a practical point that can save us from some panic and some pages for critical lab results.
The other thing I would say is please don't check labs after dialysis. They are uninterpretable. And so the potassium is going to be very low, the phosphorus is going to be very low, and you're going to want to replete it. And then you're going to give them potassium, and 6 hours later, the potassium is going to be really high, and the nephrology team is going to be really upset with you. So don't check the labs for at least 6 hours after dialysis to let them equilibrate and to be more reflective of their true physiology.
All right, so do not check the BMP right after a dialysis session, right? And I think understanding what's actually happening with dialysis helps me at least appreciate why we should wait at least a few hours for equilibration to happen.
A very practical takeaway. All right, let's recap Pearl 1. Dialysis is accomplishing two things: the clearance of toxins and ultrafiltration of volume. Next, a well dialyzed patient gets 1/7 the clearance of normal kidneys, which is why the creatinine number of 7 is expected. Finally, don't check labs until at least a few hours after dialysis to allow for equilibration.
All right, next pearl is short and sweet, but we intentionally chunked it separately because it is such an important point.
And it is that ESKD patients are physiologically distinct. It's kind of like a tide pool at the ocean's edge, born of the same sea, but governed by different forces.
Nathan. Okay, so to translate what Nathan is saying into English, he just loves nephrology that much. What I think he's trying to paint is the picture that we can't assume that the medicine we know for all our other patient automatically maps out to our patients who are on dialysis.
Dialysis patient, we very rarely see an acute myocardial infarction. Most patients are dying of cardiovascular disease, but that's not ischemic cardiovascular disease. That's a unique type of cardiovascular disease defined by Monkeberg's arterial sclerosis, the medial calcification. And if you ever get the opportunity to go to an autopsy of a dialysis patient, do it because it's incredibly informative. And you don't actually need to watch an autopsy of a dialysis patient, you listen to it. Because when they pull out the aorta, it sounds like this. It's incredible. Their vessels are like lead pipes. And so they're dying from hemodynamic complications of these lead pipes. They're not dying from acute plugs and acute myocardial infarctions. They're dying from LVH, from ventricular hypertrophy, from abnormal myocardial remodeling. A heart on dialysis is fibrotic, and it's global fibrotic. So the physiology is so different from these individuals. And so the things that you accept as normal in general medicine often doesn't apply. Basic questions: anticoagulation and atrial fibrillation.
Okay, that is such a humbling reminder. Lead pipe vessels, global cardiac fibrosis, these are not our standard patients with hypertension. And that helps explain, as we'll see in the following pearls and in the next episode, why our typical blood pressure rules don't often apply to these patients.
Now that the stage is set, we can let the play begin. Here's what Dr. Danziger highlighted as one of the biggest takeaways in caring for these patients.
Please just figure out fluid management because that's really how you're going to help your patients in the dialysis. It's fluid management. Nothing else is more important.
Okay, nothing more important. I also sat down with Dr. Erica Drury, a nephrologist at University of Rochester, who helped break down very practically how she approaches fluid management. And it starts with thinking critically about the dry weight.
The dry weight is defined as the weight at which a patient has no volume overload. And this is a weight that is determined clinically. And dry weight is going to change during a patient's lifetime. So if someone gains nutritional body weight, like they've gained muscle mass or fat mass, their dry weight is also going to go up. Or if they've lost muscle mass, fat mass, and of other body weight, their dry weight is going to go down. So it's something that we cannot just set it and forget it. We have to continually reassess, is this an appropriate target dry weight for a patient?
Man, that point of changes in muscle and fat mass over time really hits home. I recently had this patient who said she used to weigh 220 pounds and then unfortunately had a whole year of being in and out of the hospital, being mostly bedbound and losing muscle. And in front of me was 190 pounds in her AM standing weights. And in one sense, on paper, yeah, it looked like she was well below her dry weight, but actually there was a lot of fat redistribution and she was quite overloaded. And so that was just so memorable to me and it really helped hammer home the idea that if we're just trending the weight number alone without context, we can really be misled.
Yeah, thanks for sharing that story, Shreya. I think it really paints the dilemma in my mind.
Yeah.
So it makes me wonder, when should we be pushing that dry weight lower or just questioning it?
Yeah.
I would argue that we should always be trying to push someone's dry weight down, or always at least think about pushing it down, because a lot of dialysis patients do have volume overload when it's not quite obvious. You walk by the patient and you look at them and examine them. They don't have peripheral edema, their lungs sound pretty clear, but that's the limit of your exam. But they might have true volume overload, maybe even call it subclinical. So I think it's always important to try and consider, could I put this patient's dry weight a little bit lower? Could I challenge their dry weight?
All good points to bring up. So let's talk about the elephant in the room. Why do we care so much about this? Why does fluid management matter so much?
In most dialysis patients, hypertension is often related to volume overload. So the first way to address hypertension is not by adding a blood pressure medication, but by trying to make sure that we are achieving an appropriate dry weight.
Ha, so this is the real mindset or mantra that we all need to take away. It's going to be volume first and then blood pressure second, right? And we actually have trial data to back this up.
We do. There's this study, the DRIP trial, that showed that just reducing dry weight alone, without any adjustments to medications, made a significant impact on patients' blood pressure.
Yeah. So the thing that was surprising to me was that the people enrolled in this trial did not look volume overloaded. No over edema, lungs were clear. Yet, the subclinical volume overload was enough to drive up blood pressure. And so you don't have to be so overtly overloaded to raise pressures.
Exactamundo.
Yes. And maybe we can just sit with this idea of like, why is it that extra volume can lead to elevations in blood pressure? And I think it goes back to the idea we talked about in Pearl 2 about these patients on dialysis. They have these relatively rigid lead pipe vessels.
Right. If we think what normally happens when intravascular volume increases and blood pressure is rising, a normal patient's blood vessels will respond by relaxing to relieve that pressure. So, in these ESKD patients that have these stiff lead pipe vessels, they can't relax as well. So, even a mild increase in volume leads to a significant increase in blood pressure.
Yeah, it kind of sucks, right? Like these patients are in double bind. Their volume comes in, right? They need to drink, they can't excrete it. And then at the same time, their vessels can't easily adapt.
What happens if you've had longstanding hypertension and longstanding chronic kidney disease, like all of the dialysis patients have? Well, that ventricle begins to thicken. And so for each, milliliter of blood that fills, the pressure within the ventricle is higher. And so there's a very steep part of the diastolic filling curve during the fill cycle of diastolic filling for most dialysis patients. And why that's important is because they can get into pulmonary flash, into pulmonary edema very, very quickly.
So steep diastolic filling curve means extra volume can shoot ventricular pressures up, and before we know it, patients can be in florid pulmonary edema.
I have a patient, I think that's a great example of this. So, a dialysis patient that had been new to me several years ago because he had switched dialysis clinics. And in reviewing his history, he had frequent hospitalizations for severe hypertension that was relatively acute onset, pulmonary edema, acute hypoxic respiratory failure. He would sometimes end up on BiPAP and require IV antihypertensives. And then we would do an ultrafiltration session or two, and we'd get his blood pressure down. And then maybe a blood pressure medication would be added in the hospital. And then upon discharge, the same thing would happen again months later. And after a lot of education with him on reducing his sodium intake, which was actually quite high, and really pushing his dry weight down, even when he did not seem to look very volume overloaded when we saw him, but his blood pressures pre-dialysis were always quite high, we were able to get him to a point where I was able to take him off of all of his blood pressure medications. And he had beautiful blood pressures. We were taking off only a few liters of fluid with dialysis sessions, and he had not gone to the hospital in a couple years because we were able to achieve a really nice dry weight for him, which subsequently managed his blood pressure. I think we got it down like a good 10 kilos.
10 kilos? Wow. Someone carrying around 10 kilos of extra fluid and just being hospitalized repeatedly, being discharged on different blood pressure meds. And the answer was really in the dry weight the whole time, not medication number 5 or 6. It was volume.
I know. What a powerful story, Shreya.
Yeah.
So, to recap, estimated dry weight is the cornerstone of dialysis care. It's clinically determined, changes over time, especially when someone's muscle mass might be changing, like the story you shared, Shreya. And we should always be asking if we can push it lower, especially when blood pressure is elevated.
Yeah. And then I think for me, the next time I see someone's blood pressure flagged as red in a patient who is on dialysis, I'll think a little bit more about, can we push that dry weight down a little bit? And is it volume that's contributing, right? We have evidence from that drip trial that even modest dry weight reductions can improve blood pressure, even in people who don't have overt edema.
So, what happens when we're not staying on top of that dry weight? We end up in what Dr. Danziger calls a seesaw pattern.
Right now, if you think about Monday, Wednesday, Friday dialysis, they gain fluid, we take it off. They gain fluid, we take it off, a seesaw pattern. And if you could kind of blunt that to more of like a gentle sine wave so that their intake was less, I think that would help our dialysis procedure because then we wouldn't have to take off as much.
So fluid builds up, we pull it off. Fluid builds up, we pull it off over and over.
And that seesaw isn't just a numbers problem. I had a chance to sit down with David Rush, a patient on hemodialysis since his 20s. He described what this is actually like.
Taking off 3 kilos at a time or 4 kilos. Some people I remember back in the days, 5, 6, when I didn't understand what that meant. It's very taxing on the body. When I'm done with treatment, the most honest effect that I can tell you what I feel like a little bit is like a lava lamp. I'm just kind of just moving around and everything a little washy. My vision's a little blurry, bright light. It gets a really bright vision in my eyes a little bit. And those are just my personal effects.
Hmm, a lava lamp, man. That's what aggressive fluid removal feels like, and even much worse when we let our patients get too far behind.
And one of our reviewers, the wonderful Dr. Jeff William, pointed out that sometimes fluid removal is tricky in the real world. People can get symptomatic hypotension, like cramping, nausea, or headaches, with even modest fluid removal. So the less fluid that has to come off, the better the session goes.
Yes. So then how do we stay on top of it, right? Like, Nathan, you talk to so many nephrologists. I'm curious, what did you take away from talking to them, and what have you changed in your practice to help with fluid management?
Yes, fortunately, we're in luck. And it starts with simple counseling. We love talking about fluid restriction, but the real money is in the salt.
It's not about drinking the water. That's secondary. The primary issue is a low salt diet because if they eat salty food, they're going to be incredibly thirsty and they're going to drink water, right? You can't extinguish the thirst mechanism. So you really have to counsel all your CKD patients, all your patients with hypertension, and definitely all your dialysis patients about salt reduction, processed food reduction, reduce dietary sodium. It's absolutely critical. It might be the most important thing that they can do.
Ultimately, the reasoning to limit sodium is to limit the subsequent fluid intake. Because if patients are not peeing, they're literally like a box. What comes in doesn't come out until dialysis.
So I'm holding all this water in, and treatment is my only way to dispel this water. So if my dry weight, let's say, is a 138.5, and I'm gaining, 3, 4 kilos over time, I have to now drag that off of me during the treatment, which can be very taxing, cramping, all those things can happen, drop in blood pressure. All those things happen during that time of trying to pull off that much fluid.
And David actually had some really practical tips he's learned over the years for managing this day to day.
Fruits, yeah, they have water in them, but if you eat fruits a little more, it refreshes you a little more. You don't have to drink a bottle. And if you do, I would put things in smaller cups or range it by bottles. If you know that if you drink 4 bottles for the day, you're going to gain 2.2 kilos, and that's your max that you can go on treatment, then I would just stick with those $4 a day and maybe put some fruit and stuff like that. So it's just learning dry weight, understanding dry weight, being proactive in your fluid intake and knowing what you're putting into your body.
Oh, I love that trick with the fruits and definitely going to suggest that to my patients next time. And then David also had this remarkable story about what happened to him when he changed his diet more dramatically.
The doctor said, if you can slow your meat intake down, I stopped eating meat completely from that day. And when that happened, and with the help of home dialysis and doing more dialysis, daily dialysis treatments, my blood pressure subsided. And I got off all 7 blood pressure medications. Now I'm not on one. And my blood pressure now runs between 125 over 60, over 58 with no medication. And it had to do mostly with the diet, salt intake, meats, and of course, home dialysis. Doing more dialysis at home helps sustain my blood pressure.
I love a winning story. It is so inspiring. I mean, diet changes are harder said than done, and I think we all know that. But I think definitely inspires me to still try to do good counseling around salt, maybe tricks around even fruits, and of course, point out where there may be hidden salt, right? Especially processed meat. And gosh, this David was able to get off 7 meds.
Yes, quite incredible. So let's recap Parallel 4 on fluid management. We're trying to avoid the seesaw pattern, where fluid is building up between sessions and then needing aggressive removal during dialysis. And that makes the entire dialysis experience miserable for patients, not to mention the cramps, low blood pressure, and other side effects that happen with intense fluid removal.
Definitely. And then from the prevention perspective, the money's in the salt, right? Not just the water. And it's really because the salt is going to drive the thirst. And then the thirst, of course, drives fluid gain. Okay, so what if our patient is still peeing, aka still has this residual kidney function? That kind of changes things, and we have a little bit more options. So, how do we best minimize a seesaw pattern beyond just salt counseling in patients who have residual kidney function?
If I'm starting a CKD patient on dialysis for the first time and they're already on a daily diuretic, what I'll typically do is I keep them on the diuretic, but I change it to non dialysis days because when we're dialyzing someone, we're often trying to take a little bit of fluid off. And if they take their diuretic on their dialysis day, you really don't need both oftentimes. So I'll often keep the diuretic going, but just switch it to non dialysis days only. Why do we keep it going? If they're still urinating a lot, take advantage of that urine output to manage their volume status.
So many patients still make meaningful urine when they first start dialysis, even though it's not enough for adequate clearance on its own. Over time, as residual function is lost, achieving dry weight gets harder and harder. So while our patient has residual function, we should definitely try to leverage and preserve it.
Yeah. Speaking of preserving, sometimes I get scared of the doses just because I'm like,
Mm,
whoa, is that high dose going to hurt this patient?
You can use pretty high doses of
Mhm.
diuretics because these patients have very low GFRs, right? They have
Yeah.
very low GFRs. So you need a lot of diuretic to actually have an effect. So pick your loop diuretic of choice, and you do not need to be worried about the high doses because that's what they need.
Another aha is about how much fluid we can actually take off on non dialysis days and how we might be undershooting it on non dialysis days out of unnecessary caution.
Yeah, I think the classic teaching when we really want to get fluid off is okay, net negative 1 to 2 liters per day.
When you give someone a diuretic, you pee out salt and water, and initially that comes from the intravascular space, but very, very quickly it's refilled from the interstitial space. And so, really, I think if you wanted to know what a question is like, how much fluid can you take off a day in a person? How quickly does this person move salt and water from the interstitium into the intravascular space? And if you can answer that, I can tell you 100% people can take off way more than 1 to 2 liters. That's not predicated on anything. And how do I know that? Is because we could take the sickest patients in the world, we put them on dialysis, and we take off 1 or 2 liters in 4 hours, and they're fine. And so, why we, in a 24-hour basis, will we only take off 1 or 2 liters? We're doing exponentially higher during their dialysis session, and they can refill. Those refill rates, the refill rates from the interstitium to the vasculature, have been studied and generally have been defined.
So let me reiterate this because plasma refill rate was a new concept to me. When we remove fluid with a diuretic or dialysis, the intravascular space will refill from the interstitium. The rate at which that refill happens determines how much fluid you can safely remove.
The biggest determinant of what that rate is heart function. And so if you've got a really crappy heart and you've got, systolic ejection fraction of 15 or 20%, the refill rate is about 500 cc's per hour. If you've got a great heart and you're normal, it's probably closer to 2 liters an hour.
Okay, so the patient's cardiac function is one of the biggest factors with how aggressive we can diurese on non dialysis days. But of course, there's more nuance than just ejection fraction.
Hearing this has certainly helped me move beyond the reflexive 1 to 2 liters max mindset when they need more fluid off.
Yeah, same. And then I think the other thing to say out loud is, when do we stop the diuretic altogether in a patient who's on dialysis?
If someone is making like less than a cup of urine a day, I stop the loop diuretic.
Okay, less than a cup a day, we can stop. Good to know.
So, to recap, on the clinical side, if we need to be aggressive with fluid removal, we can often pull more than 1 to 2 liters on non dialysis days, depending on cardiac function and plasma refill rate. For diuretics, switch to use on non dialysis days, use high doses if needed given the low GFR, and stop entirely when urine output drops below a cup a day.
Yeah, and with that, that is a wrap for today's episode. If you found it helpful, our ask is to please share it with one other colleague, a team of yours, anyone else who might find this episode helpful.
Thank you so much to our peer reviewers, Dr. Jeff William, Dr. Jeff Cott, and Dr. Matthew Sparks.
And as always, we love hearing feedback. Please email us at hello@coreimpodcast.com.
And a huge thank you to David Rush for sharing his experience and his wisdom so generously throughout these episodes. We hope you now have a greater appreciation for the magic of dialysis.
I definitely do. And then last but not least, there's one last practical point that just came up over and over in our conversations. We didn't know where to put it, but I thought it'd be a good way to end.
A lot of times, patients who are on long-term hemodialysis, all of those records are in a separate medical record system because a lot of these patients are getting dialysis at large dialysis organizations that aren't directly associated with or connected with your institution. And so there's a lot of data there that you might not have access to. But if you have questions about what's going on in dialysis, maybe they came in with chest pain during dialysis, you don't really know what the story was, you can certainly just call the dialysis center and talk to one of the nurses that took care of them that day and get a lot of information from them. Their outpatient nephrologist or nephrology team is a really great source of information, again, because at least I know where I work, a lot of this is hidden from the medical team.
Yay.
Nice. Let's go. How do you
Let's
feel
do it.
about one? I thought
It was
good.
good. Yeah, I liked it. Good energy. Okay, let's keep it up.
Most people don't realize how much their personal information is being bought and sold every day. Data brokers are making billions, pulling details about you from public records and the internet, and then packaging and selling it, usually without your consent. That's how your information lands in the hands of scammers, spammers, even stalkers. It's why you get endless robocalls and why ads seem to follow you everywhere. That's where Aura comes in. Aura actively removes your data from broker sites and keeps it off. They also instantly alert you if your information shows up in a breach or on the dark web. But Aura goes beyond data protection. With one app, you get a VPN, antivirus, password manager, spam call protection, dark web monitoring, and even up to $5 million in identity theft insurance, all backed by 24/7 US-based fraud support. Other companies might sell just credit monitoring or just a VPN. Aura gives you all of it, together, at the same price competitors charge for just one service. Start your free trial today at aura.com/remove. Protect yourself now at aura.com/remove.